Okay, well, I will just pass the microphone back and forth, but I wanted to start because a lot of you mentioned different types of therapies, and I think an important therapy to consider are just around clinical trials. So can we just have a discussion about clinical trials, the importance of trials, when to consider joining a trial? Like, do you even consider it at a smoldering stage or even something like that? I just kind of want to open it up to your opinions on trials, generally speaking. I just want to let you know, too, I participated recently in the CARTITUDE-4 study here at Huntsman. I cry when I think about it, so I can't think about it too hard, with Dr. Saborov, who helped me get into that trial to do cilta-cel. And it was a remarkable experience. I feel so fortunate to have had it done. It was an incredible place to have it done, and he just was advocated for me so hard that I'm just so grateful. So it can be such an important tool for patients, regardless of the time that they consider doing it. So, and sorry, we're jerry-rigged here.
I've actually never seen something like this before. Let's see. I'm going to leave the smoldering question to Craig. So I think the most important thing to remember about clinical trials is that the progress that we've made to date is because of clinical trials, right? That's part of the movement, and that's one of the reasons that the myeloma therapies are evolving so quickly, is that not only do we have new drugs, but we have patients who are willing to be participants in moving those drugs forward, okay? So clinical trials is fundamental to moving the entire field forward, fundamental to offer you all new treatments. As far as when to go on a clinical trial, I think that at every phase of the disease, it's important to consider clinical trials. We were fortunate to be on the Griffin trial, which is basically changing standard of care in induction therapy. We have clinical trials all the way through maintenance and relapse refractory disease. And at each step of the way, we're providing opportunities for you guys to be part of this progress. And we're making a lot of headway.
Yeah, I would just say, like I said in my talk, particularly if you have myeloma that's come back, I think this is a very good time to think about a clinical trial. And some people, well, first of all, I think it's really important that you hear about it from your provider, you know, whether it's a physician or a nurse practitioner. But one of the things that really helps determine whether people join a clinical trial is it's explained to you well. I think that's very, very clear from the research that's done. And I think also what a thing that I hear from patients sometimes is, well, I don't want to be a guinea pig. And I get that, but at the same time, I think people don't understand how carefully constructed these trials are. They go through many levels of inspection by outside parties to try to make sure that they're not just safe, but they're actually reasonable. In other words, that you will get a benefit potentially, or you often at least get standard of care. Now, just like Jenny described, that particular trial was really something that was quite different than had been around. And she was, there are some trials where you're asked to have maybe just what's around and not the new thing, but typically they really can provide you access to interventions that you otherwise can't get.
Okay, I'm supposed to deal with smoldering. So the difference between me, Natalie, well, just me and Natalie, beyond my fabulous hair, is the fact that we are at different institutions that have different access to different trials, different things that are open at different times. We're all academic myeloma docs, so we have many more similarities than we have differences. And when you're going to see a doc for your myeloma, remember that you are 2% of all cancers. Your average doc does not see myeloma professionally. They see 5 myeloma patients in a year. And that's because myeloma is 2% of all cancers. And so if you're seeing a myeloma professional, then what's different between us, while we love to say that we give Zometa differently or this and that, really the difference is that different institutions have different access to trials. And when you are talking with your doctor about trials, everyone should be able to say what they're getting out of it. And everyone should be pretty upfront about it. Patients are looking for a treatment that will help. The physician that you see is getting recognition, publication, etc. The drug company is pushing a drug to get approved. Any number of things that are going on, you want to have all of that pretty upfront and transparent. And that goes as well to the mechanisms of the trial. What is required? Oh, we have trials at our institution for MGUS. We have trials at our institution for smoldering myeloma. Okay, what does this require? How many extra visits do I need to take? How are you going to poke and prod me, and what would normally happen if I wasn't poked and prodded? These are the things that help patients figure out the balance. What is the risks and benefits of heading towards this clinical trial? What am I getting out of it? And how much is it going to cost me? And none of that is about money. It's all about, in general, different procedures, different responses, different treatments. So having a clear conversation with your doctor about what is available and then what makes the best sense. You're only going to get into a trial where ethically it's just as good as anything else you might get in at the time, because that's how we created the trials. The trials were created such that we can't make those errors. But everything else about the trial is worth talking about and trying to make sure that you understand what you're getting out of it and what it's going to cost you in terms of additional procedures, visits, etc., is the type of information that should occur in the consent. And the consent is a disaster. In the vast majority of clinical trials, they are written by a regulatory person who's just reading over the protocol and putting in these tables that create a 64-page document of mush, which is very difficult to get through. And in fact, most of my job is trying to break down for the patient exactly what is required and what they should view to get out of it and what are the risks. And I think that if these consent forms were written better, we would be able to give patients a better picture of it. And there's no spot in my clinic and no patient I see where I don't think, hey, is there a clinical trial for this available? Is this a situation where this patient where the benefits outweigh the risks for clinical trial participation for this MGUS patient, the smoldering patient, the newly diagnosed patient, the transplant patient, et cetera, et cetera. So there's no spot where we're not trying to do it different or make it better.
Okay, that's great. And I do want to just point out again that depending on the institution gets they get to kind of decide their strategy about their clinical trial strategy. Because like when I first came to Huntsman, there were really very few, if any, clinical trials being run here. And what I've noticed you do in the program is build up kind of a full suite of clinical trials for the newly diagnosed patient, for the smoldering myeloma patient, for the relapse refractory, or in different settings. And the three of you all have that. But that doesn't happen at every facility. So I want to reiterate your point that at different institutions, there are different trials open. So you may not always have, your doctor may not always talk to you about the clinical trials that are open, but ask about the trials that are open. And if you learn about a trial that you want to join that might not be open at your facility, that's an option too. So, and your doctor can help you facilitate you joining a study if something's not open. So anyway, just consider that. Like, for example, there's a trial called the Ariga trial. It's like a newly diagnosed. So how do you reach newly diagnosed patients who want to get maybe daratumumab as their maintenance therapy or something like that? You know, how do you do that? You don't, it's hard for the newly diagnosed patient who's just totally blown away by the fact they have myeloma, actually, to think about joining a clinical trial, but you could get early access to things potentially. So you need to kind of understand, how do the trials work? What are the arms? And anyway, thank you for your conversation about that. I kind of want to ask a a kind of a thought-provoking question. Dr. Callender, you talked about this a little bit, that we don't quite know what the sequencing looks like for this. But when I was diagnosed in 2010, I never ever heard the word cure. If myeloma experts ever used the word cure, they were kind of mocked, and that was not going to ever be in the pathway. I hear you as investigators talking about that as a potential. Maybe it's not for all patients. Maybe it's for a subset of lower risk patients, or maybe it's for 11-14 patients, or maybe it's, but how do we get to that path? What are you seeing change in terms of the sequencing or the use? I mean, you talked about like bringing up CAR T earlier in lines of therapy. How do you do that with therapies that are immune system function? Like if you're looking at transplant, you're looking at a bispecific, you're looking at CAR T, all of that is utilizing the immune system. So you do burn it out at some point, or like when do you use it? When is it the strongest? Anyway, just kind of want to facilitate a discussion about how you think about it as myeloma experts.
Want to start down there? You want me to
We can go backwards. Sure.
Crap. Okay. Just did not want this one. So the idea of cure, when I think about cure, I am thinking about the patient where I said, don't come back because you're done. You don't need to see a hematologist ever again. I'm done with you, and hematology is done with you. That's my view of cure. And everything else is about risk and what's going to happen in likelihoods. And it's more like my retirement planning than anything else. Like, oh, what is the chances that I'll reach this amount? That's one thing. I think in terms of how do we get closer to a cure, I think, again, having more patients being treated at academic centers like this so that more than 2% of myeloma patients participate in clinical trials, and so we get a diverse population of patients onto clinical trials. And in terms of sequencing, I think that I am less worried about the sequencing of treatments damaging or changing the patient's innate immune system than I am about every treatment affecting the patient's population of myeloma cells. For instance, CAR T. For ida-cell patients, this is the BMS CAR T. We know that these CAR Ts often will die out 6 months into it, and hence patients are basically without therapy at that point, and their myeloma is going to come back. We just don't know exactly when. And the situation is similar to cilta-cel, but with some caveats. I'm less worried that I've irrevocably damaged their immune system. I'm more understanding about the fact that my little CAR T warriors are gone, and they won't last forever. And that means that a bispecific is available at some point, whereas if we switch that and somebody was continually getting a BCMA bispecific, an antibody targeted towards that protein, and then they became resistant to that, well, then I'd be very uninclined to use a BCMA CAR T in that patient because they've already shown themselves to be resistant for expression on their cell surface of that BCMA. And I leave it to my colleagues to address some of the other tough issues.
Well, I want to approach this by a little bit of a different point of view. I do transplants for different blood disorders, not just myeloma. I think you all do as well. Yes? So one of the things that's been very clear to me throughout my career is we know that if we send people with certain blood disorders like lymphoma and leukemia through, say, a transplant, a donor transplant, after a certain couple of years, pretty much not going to come back. Now, that's not been true in myeloma, and that is even true with donor transplants for myeloma, which is one of the reasons that they sort of fell out. So I'm actually very interested in treatments that might restore equilibrium, more than just say, you have to eradicate every last cell. And people talk about perhaps what we'd like to do is get everybody back to this sort of very early precursor, something that we call MGUS, or monoclonal gammopathy, where you might have some plasma cells, some myeloma cells still around, but you've kind of sequestered them, and your immune system is taking over and just sort of roping them off, if you will. And I think that may be, in the long run, a more realistic goal and might get us to a better place, because anytime we hit hard and really try to reduce myeloma cells, because of what they do normally in the body, those plasma cells, you are hitting hard on other important parts of the immune system. And I will be the first person to admit this is all quite complicated, but I think we really have to sort of include the idea that maybe you want to think about the normal systems in the body too, and try to include them and get everybody more to a balance rather than annihilation.
At least we always end with a bald guy. Geez, this is such a hard question. So I'm one of those people who's not using that C word yet. I think that for the most part, we're stuck in this myeloma academics, clinical trialists are stuck in this, well, let's just add more. So if 3 drugs was good, let's add another drug that we think is good. Okay, well, maybe that's better. And Craig showed that slide that, you know, with Griffin, you're looking at a progression-free survival of, you know, however long, much longer than anything we've seen. Well, maybe we should add another drug to that. Okay, well then, you know, speaking to Jenny's point, then we start mucking up the system. We get further away from that homeostasis, that equilibrium. And so I think that it really calls into, it really highlights the importance of the work that's being done, not only in the clinic, but in the lab. And we're working towards identifying what those myeloma stem cells look like, identifying different therapies that we can incorporate into patients' treatment that are not just controlling the active clones that we have or the active disease that we have, but really getting deeper and getting rid of these cells altogether. And so I think that the work is being done. I think that we're inching closer to it, but I think that there's a lot of work that's left to do.
Okay, last question, and Greg is flagging me down, so we have to be quick. How important is it for myeloma patients to understand the type of myeloma that they have, genetically speaking, or what does that change in the way you practice myeloma care?
Can I take your turn?
Okay. Well, I'll try to be brief. Well, we do know that there are some people who look ahead of time like they're going to have a little bit of a harder time with their myeloma. Usually that means that at first treatment, they're going to respond probably just as well as anybody else, but they may have a relapse much more quickly. So we can identify some of those people, but honestly not all of those people. So I think it is good to know maybe where you fall in that spectrum. But the other thing I think is very important to know is, how is your provider tracking your myeloma? You know, I mentioned some things in my talk. You have to realize that that can change over time, that sometimes you stop making protein or you only make light chains. The more that you're aware of what is being tracked, and people sometimes come to me and say, what's the one lab test I should look at? But it's not one lab test. It's sort of all of you. So are you anemic? Are your kidneys chugging along? You know, how about those protein levels? What's happening with your other antibody levels? So it is very good to be informed about all of that.
You can mic drop it right there. Well done. Well done.
I'm just going to pick up the mic just for a second. I think that expectations are very important, and having an honest conversation about what we're looking at in the first year, the second year, you know, ongoing. And so understanding those features about the disease and having that very frank and honest discussion with your provider is really important, because, you know, you can go online and you can say, well, you know, Jim from Kentucky, you know, at 10 years is still alive and he hasn't been on maintenance therapy for, you know, 8 years, right? But then you could have very different disease. And so I think it's really important to understand that myeloma is heterogeneous. It's not just one type of disease. And everybody's disease is going to act a little bit differently. So I think that that's an important key piece.
Okay. Okay, and with that, I just wanted to have a little plug for HealthTree Cure Hub, because this is what we can help you do. In HealthTree Cure Hub is track some of that, so it'll, you know, help you flag like when you need to. We find this more in the general oncology setting than we don't find this in the academic center setting with myeloma specialists necessarily, but sometimes in the general oncology setting, when you're going to a community provider, they may not be tracking as much as you do at the academic center, so you kind of need to take that on also yourself. I know it doesn't seem fair, but you do need to be aware of your own disease and how it's trending, so you can catch things early and not wait for end organ damage. So thank you very much, very, very much.
Thank you.
Get out of here.
Okay, I will.
So this is the part of the program, the reason we call these round tables, I want you to visualize not a round table discussion, one word, but the table, a nice round table like in King Arthur's court. And this is where we're all equal here. We're all sitting at the front of the table. And one of the reasons I pushed that session back is because Dr. Callender has to leave after lunch, so I didn't want to, you know, take away any time from her. And the other thing I like about these Q&As that we do is this is a time for you, you know, we all know they know a lot, but honestly we really don't care about that. What we really care about is what do they think. And that's what we're all about here. So this is going to be a little different. I'm going to ask the speakers, when a question is asked for our online audience, if you could repeat it in the mic, because they won't hear it. And just do, you know, like at the auctions, just give me a signal, you know, that you want to speak, and I will sort of order you along, and I hope you think of good questions. We're going to do this again in the afternoon, and Dr. Hoffmeister will be there again, and you can grill him with the hardest questions you want.
So, the softballs right now, right?
So who would like to begin? I'll start right here, here, and here.
Hi.
Do you want the microphone?
No, that's why you have to repeat the question.
Oh, okay. So I was 120 pounds before myeloma. I was wondering if my metabolism changed because of the myeloma and or medication. Now I'm 183.
The question is, what happened over the course of therapy, and why did you go from a baseline weight to now gaining weight? And is it myeloma, or is it medication, or is it a combination of the two? So my guess is that you've seen quite a bit of our favorite friend dexamethasone. And you know, that's really one of the most profound issues with the dexamethasone. There's, as all of you know, or most of you know, there are a lot of other problems associated with it, but that's the big one. And so my guess is that that's been the biggest culprit in you. As far as metabolism, I can't necessarily speak to that, but I will say that the dexamethasone questions is a very interesting one, and I think that, at least in my practice, I've started moving away from the long-term high doses of dexamethasone. I think that it plays a role, especially newly diagnosed, in the newly diagnosed setting, or when the disease is particularly active. It also helps a lot with drug tolerability. So it definitely has a prominent role in our therapies. But I think the long-term exposure to steroids, I think we're all realizing that it causes a lot of problems. And so we really have to walk that fine line of risks and benefits in regard to dexamethasone exposure. You guys want to add something?
Yeah, so again, towards metabolism and what can lead to weight gain, you know, as Doug mentioned, steroids. So one of the other things they do besides tending to gain weight is they'll make your muscles weaker. So they make your big muscles, as we call your thighs, your upper arms. So people get weaker, then they do less, then they're expending less energy. And you get into, unfortunately, a really vicious cycle sometimes where the less you do, the less you do. So just as Doug mentioned, I think we're all getting smarter about this, to say using less steroids, but also really encouraging any kind of activity that you can do. If it's the couch pedal that you can do with those, do it. If it's small weights, do it. But really your friend here is physical activity. And I'm so pleased that you're emphasizing that in HealthTree, because that's a big thing that we have been very lax on, I think, on the MD side in terms of promoting that.
I have a question about targets. Primarily the target seems to be BCMA today. What other targets are out there, or what kind of targets are investigators looking at other targets? And what can you say about that?
Right. So BCMA was the first out of the gate, but you'll see a lot of other targets coming up. On either this Wednesday or last Wednesday, New England Journal of Medicine put in some 19 patient phase 1 of GPRC5D CAR T cell, so that's a different target. And these targets will just continue to move on as we focus on different proteins on the cell surface of primarily plasma cells that we can use therapeutically. We're also going to focus not only on the targets, the things on the cell surface of the myeloma cell, but who's attacking the myeloma cell, which cell is involved. Are you giving it a T cell? Is it an NK cell? Is it a macrophage? Which parts of the immune system can you harness to attack? And you'll notice, drugs like Blenrep is an antibody drug conjugate. So it's targeted towards BCMA, but it brings a poison payload to the thing. So we're looking at different targets, different cells, and then different mechanisms to try to kill myeloma cells.
One thing about roundtables as well is these are basically one-room classrooms. And so we have newly diagnosed first graders and really experienced 12th graders sitting in the same room. So don't be afraid, oh, my question's not really that complicated, because trust me, on our online audience, there are people who want to ask these questions. So, ask anything you want, and remember to please repeat the question.
I think I'm in second grade. Can you talk a little bit about the stem cell transplants? What to expect?
Sure. So let's talk a little bit about stem cell transplants. Stem cell transplants go back to the 1980s, and at that point there was one drug only, melphalan. Well, I guess there's two. There was cyclophosphamide and maybe three because there was prednisone. So that was the case for 30 years. So nobody knew what to do. So the logic was, well, let's just use a whole lot of melphalan and we'll see if we can make people better. So this was done in a handful of patients in the mid-1980s without stem cells, and they said, boy, this kind of works, but people get really low blood counts. So that led to the whole idea, first of all, of giving bone marrow, which was what was done initially, and then more recently stem cells. So the way we do stem cell transplants, it's the #1 reason a person has a transplant in the world, and it's been studied up and down and back and forth. So we still do it much the same way. Between our 3 institutions, I doubt there's a much variation, but there's a sequence. So we first have to get stem cells out of you. That's done usually with a combination of drugs. Once that's done, they can be put in the freezer for a decade or more and used much later, or you can use them right away. Then I'm sure, except outside of a trial, we're all using the same old drug, melphalan. Some people split it in half, some people give it on one day, but we all use melphalan. You tend to get it and be asked to chew a mouthful of ice or popsicles. This was thought up by a nurse, very effective. It seems to prevent mouth sores. The melphalan is given, washes out in a day or two, then they infuse your cells through your vein. They're smart, they just go in the bone marrow and they start growing. So then there's a period of about, from the time the cells go in till new cells grow back, it's about 10 days or so before you start seeing the first kind of shoots, if you will, of cells coming out. So I don't want to monopolize all this. Let me pass it. No, I can pass it. But there are very predictable side effects that happen. Diarrhea is very common, fatigue, loss of taste, loss of appetite, There's a risk of infection. About 7 out of 10 people have a fever. We all have our antibiotic cocktails that we do prophylactically. Some centers put people in the hospital for all of this. Some people put it in for part, and some people put it in for none. But whether you're doing it in Utah or Georgia or Madison, Wisconsin, the recovery time, it's all about the same. Why don't you talk a little bit about what to expect out of the hospital once you recover?
Absolutely. So, as Dr. Callender pointed out, these cells is very predictable. So day 10, after you get the stem cells back, the light switch is starting to go on. I sort of explained it like an old car, right? You're starting to see, you're turning the key and you get a, you know, things are happening. Day 11, maybe the cars gives you a little bit of a turnover, and then day 12, generally, after the stem cells, the car wakes up, okay? And so at that point, you now those stem cells have made their way into the bones, have set up shop, and are starting to make normal cells again, okay? So you're starting to get your immune system back. So in general, we have the GI toxicities that occur throughout the transplant process. Usually on day 8 or 9, patients have our picture up on the wall and are throwing darts at it. Yeah? But usually by day 11 or 12 and the stem cells are waking up, patients start to feel a little bit better. Okay, so once your neutrophil count, which is a type of the white blood cell, once it's above a certain level, then it's time, if you're in the hospital, it's time to go home. Okay. In general, patients have to stay within a certain boundary so to make sure that they're close. But in general, once we have discharged a patient, once they get past that day 12 or day 13, things are generally pretty safe. Okay. But there's long-acting toxicity or long-acting effects of that high dose of chemotherapy that we gave. And so it can take patients some time for that fatigue to go away. You know, we see taste changes. That can take a month or 2 to go away. So the system is sort of rebooting. One of the things to remember is that when you have your stem cells put back in, it takes them time to mature, right? So there's going to be risk for infection, not only just right after the transplant, but for months after, okay? So, you know, we ask patients to stay safe, to mask up, to make sure they're getting Evushelled, or, you know, they start their vaccines at the 6-month mark. And so there's this whole process that you have to go in or go through over the course of the post-transplant period to make sure that the system is maturing and sort of rebooting normally. I've had patients who have gone powder skiing on day 18, okay? Not that I said that they should go powder skiing on day 18, but it was a big day, and so, you know, they went. Some people will take months before that they can really, really get back to their normal activity. In general, what I tell patients is at the time of diagnosis is give me about 6 months. Okay, give me 6 months to get the disease under control, get you through the transplant period, and getting you to the point where you're starting to get back towards your baseline. At the 1-year mark, my hope is that my patients are feeling better than they felt in a long time. Right? Because before we started the myeloma therapy, the myeloma has been active for a long period of time, right? So that's sort of some of the things that we see in the post-transplant period. Every patient's different, but what's remarkable about the procedure is that on day 12 or 13, those stem cells have made it in and they set up shop, and patients at that point are safe.
And just a comment, we have a whole class on stem cell transplant in HealthTree University. And we also have a lot of coaches who contributed a lot of information to do a whole stem cell transplant guide. So we have a lot of resources that we can share. Thank you.
First of all, thank you folks for all the work you do. I had a T-cell transplant last November, so I'm coming up on 1 year. Perfectly fine, I'm doing great, haven't felt better in many years. My question is, when will that transition from being cancer-free, as they call it at Stanford, to a point where it's going to start coming back? And will I feel physical effects of it coming back, or will it just be another blood test that says my light chains are out of control?
Yeah, Craig, do you want to take it? You want me to?
No, go.
Repeat the question, please. As best you can.
Well, first of all, we got a clap.
You got the clap?
No, we didn't get the clap. We got a clap. Jeez. It's a tough crowd. I mean, Madison's not, that's a lot different than what happens here in Salt Lake City.
A little frisky.
Yes. So basically the question is patient receives ide-cel or Abecma, which is a CAR T therapy. And one of the advantages of being on a CAR T therapy is that at least currently we're not giving any therapy after. Okay, and so patients who have been heavily pretreated have this nice long period, hopefully a nice long period of not having to have treatment, which is a real treat for everybody. And the question really was, well, how is this thing going to come back, right? And so how are we going to see it? Am I going to feel it as a patient? Am I going to feel symptoms, or is it going to be lab tests or whatever? So one of the, I think the most important point is that even though you have disease control, which is what it sounds like, we have these numbers from the clinical trials that tell us, a ballpark, on average, this is about how long a patient's going to go before their disease progresses again. And so as your myeloma provider, we're saying, okay, we're thinking about that ballpark, understanding that's all on a bell curve, okay? And so you're looking at about 20 months if you've gotten a deep response from ide-cel. Okay, but that doesn't mean that we're not going to watch you until 20 months. We're going to continue watching you over the course of your post-CAR T therapy. And it's very important to be monitoring for, reconstitution of your immune system, right? Because we want you to stay safe in that space. But it's also very important that we're watching things like your light chains, right? Your M spike. Are there markers that are telling us that things might be waking up? Okay? The really interesting question is, okay, well, let's say your disease starts waking up a little bit. Maybe your M spike goes down to nothing. And then all of a sudden you have a small M spike, it's 0.1. And we do a bone marrow biopsy and you've gone from being MRD negative or not having evidence of disease in your bone marrow, and now you're MRD positive. How should we deal with that, right? And these are all questions that I will say that I don't think we have answers to at this point. But it's very, very important that you continue follow-up after the CAR T procedure, because every patient's going to respond a little bit differently.
I'd just like to add a couple of things to that. There is sort of some waves. What we have seen at our institution, the people who don't seem to get much improvement at all after CAR T, and I'm talking about people just weeks to maybe a month or more, unfortunately those people are often in really bad situation. For people who've been controlled for a long time, we're definitely seeing the ability to treat them again with other things, and that came out in the first trial, that the survival of people who went through that original Abecma transplant trial, it was much, much longer than the response to the agent, to the CAR T, meaning that once the CAR T wears out, they still were able to go on and get different treatments. So I think that that's the expectation, particularly in people who go a long time. Unfortunately, again, I don't know what you've seen, but the people who have very, very short responses or no response, I think those are really people that we are not helping very well.
It seems like the ADC, we have, the BLENREP is pretty efficacious, but the side effect profile is pretty significant as well. Are there ADCs that are in development that you're particularly excited about, or involving different drug side chains or radioactive nanoparticles or something like that is coming after you?
Well, I think, I mentioned, oh, I'm sorry. So BLENREP, the antibody drug conjugate, appears to have a lot of side effects. Are there other drugs coming of that kind? So a couple of comments. The belantamab, the antibody drug conjugate, has keratopathy, but that's about it. I mean, just to be very clear about it. It has a little bit of low platelets, but I think that's really the biggest problem. And, as Craig was mentioning, dosing may take care of a lot of that. But there are other drugs coming. I mentioned that one modakafusp, which is an antibody carrying interferon, but there are others coming. Craig, moment if you, because of your research too.
I honestly don't have other antibody drug conjugates that I'm looking forward to. You know, I think a lot of patients and predominantly their physicians need to closely follow, even for patients who are asymptomatic, on Blenrep. And because you want somebody to look at the cornea and say, hey, is this cornea healthy, even though the patient sees well. So I think changing somewhat the dosing and watching closely with every dose to make sure the cornea is not effective can allow kind of maximum use of Blenrep. And I don't have another antibody drug conjugate I'm really excited about.
I'm going to give a shameless plug for some of the work that we're doing here because I can. Blenrep is obviously the first of its kind, and it can be very effective, as you pointed out, Kyle. I think that this is an ADC that's directed against BCMA, and we have all these other BCMA drugs. And the question is can we construct an antibody drug conjugate that is targeting something else, some other antigen on the myeloma cell? The answer is yes. The question is, will it work? Another question is the current antibody drug conjugate that we have, the chemo is conjugated to the heavy chain, and so it's relatively limited as to how much chemotherapy you can deliver. And we're constructing a new, it's basically a new way to deliver more chemotherapy on the ADC, and we're able to increase the chemo load by about 1,000. And we don't think that's going to increase toxicity. So it's still very early, but I think that the concept of an antibody drug conjugate is brilliant, and I think that there's a lot of room there to grow and try to figure out how to optimize it.
Thank you. So the question about trials that was brought up earlier brings one for me, which is actually the opposite, and it's kind of a FOMO question. If you get the standard side of a trial, which I, of course, am bringing it up because that's what happened to me, and so you're always thinking, shouldn't I be on the more assertive, the latest and greatest? It's proving well in other things. And yesterday I learned that HealthTree is trying to pull the information so that the standardized side doesn't have to be, that the trial can just be on the forward-looking side. So I guess, do you have a predilection one way or the other? Do you see that as a negative, getting the standard side? Maybe just comment about that.
And repeat the question,
So the question was essentially, in randomized clinical trials, there's generally a 50% chance of getting standard of care and a 50% chance of getting standard of care plus. And so there's also other ways of getting at questions that may involve maybe retrospective data, et cetera, et cetera. And so I think the question was essentially, is it worth it for a patient to go on to a standard of care arm in a randomized prospective clinical trial? Am I sort of hitting that? So I think that randomized phase 3 clinical trials are fundamental for us to answer the question of whether one regimen is better than the other. And I think that the one thing that does not happen in myeloma in the vast, almost 100% of the time is that you're not getting a placebo. And so our clinical trials include standard of care. It's a chance, absolutely. It's a chance, absolutely. But I think that without being part of that clinical trial, we're never going to have the answer to move things forward. And the thing about, say, a newly diagnosed trial where you may have daratumumab or not, well, we know that daratumumab is very, very effective at first progression, right? So you will be getting that drug at some point. And so, yes, you may be missing it at the beginning, but you will still have access to that drug at some point. And so I think it's a very difficult question. I think it's something that you as a patient, all of you patients, when you're thinking about these randomized trials is, am I willing to do that? right? But from our perspective, it's absolutely necessary that we have these high-quality clinical trials that are looking at very valid endpoints to help us really answer the question of if one thing is better than the other.
The one thing also I want to just make clear for everybody about trials, so there's different types of trials. A phase 3 trial is looking at a standard versus something new that usually has been tested. But there are phase 2 trials where people are offered often a new combination or a new drug where everybody is going to get the same thing. And those phase 2 trials have usually been based on something that shows some good activity, as we call it. And then there are phase 1 trials where you are being asked to take a brand new compound, typically, don't know if it's going to work or not. So in terms of risk, it's probably the phase 1s that are the riskiest because you could be taking a drug that is going to have no benefit whatsoever. Now, I can imagine that every one of us here can tell you about patients that we've had on phase 3 trials getting the standard arm where they actually do better. They go into remission. So I don't think that in those trials that we really think you should worry about FOMO, that you are getting something that we think is good. There are examples out there in the myeloma world where our phase 3 trials have been negative. One of the big ones that came up recently in the past couple of years is there's a group of drugs that works great in things like lung cancer and kidney cancer and melanoma. These are checkpoint inhibitors, a drug called pembrolizumab, for example. Those were combined with standard drugs. Looked like a home run from the lab study, had a phase 2 trial, looked fantastic, caused excess death and morbidity in myeloma patients in phase 3. So it's not always great. Now, that shouldn't scare you away from a clinical trial, but I just want to say that there are times when the standard arm is good. I mean, so I think that we do try to make it so it's fair, so you're not getting inferior treatment. You're getting what the experts here would say is really the standard.
And one last comment is that the randomized clinical trials are touchy, right? They're very uncomfortable for the doctor if it's blinded and the patient all the time because it's upsetting that somebody else is deciding what treatment you're getting. And losing that control is upsetting. However it turns out, remember, is that the vast majority of myeloma patients who get treated in academic centers live longer. And partly that's because of the specialization the physician has and also because of being able to participate in clinical trials. So this has been published in myeloma, it's been published in leukemia. You're still part of, in essence, the winning team, even if that arm on that particular trial may or may not work out in the end. We won't know, but in that small battle you may win or lose, but the overall war is already won through the treatment you're receiving.
I have one other comment. I always prefer YOLO rather than FOMO. YOLO is you only live once. FOMO is fear of missing out. So we'll go YOLO.
Okay, so this is basic. I am 4 weeks diagnosed, so just still learning a lot, but I have found something that I haven't been able to find too many answers on, and that is that I have the Velcade. When I get the Velcade injection, I have a injection site burn, feels like a burn with spider type looking veins that come off of that, and it burns for about a week until I have my next one, and then it's about down. And do you recommend I continue to do that, or is there other, I don't know.
Sure. So the question is about a cutaneous, a skin reaction to Velcade that is very severe and lasting almost a week, so that by the time you're getting another injection of Velcade, it's back again. There are definitely people who experience that. I think early on, now you may or may not know the reason we give Velcade like that is it used to be given intravenously and caused terribly high rates of neuropathy that way. So we've moved away from it. But there are people who have those reactions. Now, I think it's kind of controversial how you handle that. Some people have said, well, ice it, and then people have said, well, maybe that's going to limit the distribution of Velcade throughout the body. The alternative that sometimes is proposed is to just go to the different drug carfilzomib, which you could potentially do, and then you shouldn't have the reaction because that is given intravenously and it doesn't have neuropathy. I have noticed in our clinic sometimes it depends on who's administrating the Velcade, whether or not they get that reaction and the depth that it's given. Sometimes I have patients who then say, I want Jackie to give me my Velcade. I don't want Ed to give me my Velcade. So we've seen a little bit of that. I think apart from that, I'm not sure I know of a real antidote.
Yeah. The only thing we've seen is that if you inject the Velcade like it's insulin, that's in general, at an angle from the area, that's usually a bad idea. And you usually want to go perpendicular. And if you go a little deeper, usually you don't have these problems.
That was my first question. And then, how do they know that it's not the lymphodepletion of the bridging therapy, like the cyclophosphamide or something like that, is creating some of the response to CAR-T rather than the CAR-T itself? And then my last question is, if somebody doesn't have the right number of CAR-T cells that have been, they send them off the lab, they don't have enough, sometimes they don't send them back to be reinfused. Wouldn't some be better than none if the patient is going through the CAR-T cell therapy? They have to reach a certain amount. So I can repeat those if you need to, but I think they're quick answers on that.
Right. So it's CAR-T questions, CAR-T-Alusa. So number one is BCMA expression required? Do you test it beforehand? Number two is how much does the conditioning regimen, the fludarabine, Cytoxan, or whatever, manifest? And now that I said it, I just forgot the third one. But the first...
What if you get a product out of spec?
Oh, yes, and how to deal with too few CAR-T cells. And does that decrease the effectiveness of the infusion? So number one, BCMA is on the vast majority of myeloma cells. And testing for it usually is not terribly helpful, except for people who've progressed on another BCMA-directed therapy. The problem is that just because you have or don't have BCMA, your CAR-T may or may not work because the myeloma cells can sometimes create a protective cocoon even if they express the target. Number two, fludarabine and cyclophosphamide and a number of alternatives have very little anti-myeloma efficacy. And there's some early data, but it's not great, that the more immunosuppression and the higher the intensity of that lymphodepleting chemotherapy, the more the CAR-Ts have an ability to expand. But it's really hard to research that as the pharmacokinetics of the drugs are very challenging. And number three is, what if you have too few CAR-T cells that are viable and ready to go to the patient? Wouldn't that be better than nothing? And on average, the efficacy of these CAR-T cells it depends on the dose. And if you only have 10% viability, well, it's going to be a waste of time. If you wanted 100% viability and you have 97% viability, yeah, go ahead and do it. My patient who's out of spec on Carvykti coming up has, the viability is just 3% below their target. And both the data from the company and independent data would suggest it's still going to be efficacious.
Question right here.
Yep.
for the centers. What about the availability?
Well, that's an excellent question. So what about availability of clinical trials in rural America? And that is something that personally I think that I've been trying to work on with some of our cooperative groups, because what's limiting us are federal rules here. And they will require, for example, that drug has to be administered at the clinical trial site, that blood work has to be done at the clinical trial site. There is movement to try to change that and make, now we're doing telemedicine, right, with COVID, to try to make that, to listen to that kind of problem. But there is a lot of, right now, red tape to get through. Part of it is for a good reason. So they'll say, how do we know that if we send our very precious experimental drug to other than the clinical research site, that you're going to take good care of it, that you're going to store it, that you're going to protect it? That's a valid question. I mean, but I think that there are people who are very interested in this, who are going to try to loosen up some of these restrictions, like it doesn't matter if you get a CBC here in Salt Lake City or you get it in Provo, right? It's going to be the same result. So when we're looking at maybe testing that doesn't need to be done right at the clinical trial site, I think we're wide open and ready to make that move. But it's been tough to get some of our regulation department, either both in our institutions, but also on a national level through the National Cancer Institute, to get them to try to make more reasonable accommodations for this issue.
I can tell you a story about this guy who is in Columbus, Ohio, that likes to go skiing, and realize that there's a pocket of the United States that has not had access to high quality clinical trials. And that individual came to Salt Lake City and said, well, maybe there's an opportunity here for that. And that's me. So I think that, and the point I'm making is not to inflate myself, but to say that there's more opportunity that's happening throughout America. Okay, so we have a 9-state catchment area. And so one of the things that really one of the fundamental things that this program does is has a clinical trial portfolio to offer patients in this region. And so we've said to drug companies that are not cooperative group trials, but drug companies to say, well, listen, I'd love to run your trial. However, you're going to have to pay for my patients to travel down here and stay locally so that they can get these drugs. And we've actually been able to set up those budgets. And these companies have actually been very open to that. Right? Because, especially people in this region have not had access. The other thing I would say is that there's, with programs like ours in Colorado, et cetera, there's more of us interested in providing these services and these trials to our patients. And companies, cooperative groups, all of these different mechanisms for clinical trials have been open to including us in those opportunities. And so we've been able to offer things that really haven't, 10 years ago were not possible in this region. And so that's happening across the United States, and it's really a positive change.
And I have a few online questions because we have, I'll take that from you, and we will, you don't have to repeat it. Take this thing off. Wait, I had the question, oh, here it is. At what point in treatment, oh no, that wasn't, why do people relapse early from transplant, and what options do they have?
Early relapse myeloma occurs in up to about 20% of patients that we weren't expecting to have an early relapse. It's a marker of a very high risk disease. I will tell you that as all of us have a lot of these patients, we don't really know what to do. And so in general, we try to be more aggressive, and we try to utilize what we call novel therapies or novel approaches. In some patients, we consider a quad therapy at the time of the first relapse after an early progression after transplant. Some of these patients are able to go on clinical trial with CAR Ts, et cetera. But this is a space of active investigation, and I will say that we don't know what to be doing.
How do you define early?
Yeah, so I think that we're pinning down that definition now, but 18 months from the time of diagnosis in somebody who's not transplanted, 3 years in somebody who's been on maintenance therapy after transplant, and 2 years or 18 months, 18 or 24 months after transplant if they're not on maintenance therapy.
And this is a question really for newbies, but it's really important, and it's a question that is asked literally at every roundtable that we have. Along with current therapies, is it acceptable to take natural herbs and vitamin supplements? And Dr. Hoffmeister referred to that a little bit, but if you could expound on that a little bit. Want me to go over here since I've picked on you?
You love that question.
I do love this question. Just in case you've read about it, there's a bunch of posts and some published data about the use of vitamin C with bortezomib, saying, oh, you can't take vitamin C with bortezomib. And it should be better labeled, you can't take extraordinary amounts of vitamin C every 2 hours, 24/7, while on Velcade. Since nobody's doing that, I don't think it's a big concern. And the same goes for a component of green tea that, again, passionate green tea drinkers are out there somewhere, and they tend to come to my clinic and are upset that somebody's published that they can't drink green tea anymore. And we all feel a lot better when they are able to drink green tea. Beyond that, it's reasonable to remember that there's a number of drug-drug interactions that are clinically relevant, that can occur from a variety of supplements that are not spelled out to the vast majority of us who aren't pharmacists. And unless you're a pharmacist, you may not be aware of all these relevant drug interactions. The supplement industry is thought as dietary aids, so they don't have any of the regulations, and there are no restrictions on cost, and there's absolutely no compunction about advertising that it will boost your immune system. Every ad talks about boosting the immune system. And let me assure you, we know nothing about how to boost the immune system in a human. We're not bad at boosting the immune system in inbred mice. We're actually pretty good at that. But since none of you are inbred mice, it's not going to work out. So please do not spend lots of money getting stem cells or strange supplements to boost your immune system. That is not going to work.
I'm just going to say a couple of things. I can't support that more, but two things. Sometimes I have patients coming in saying, somebody told me about this. This is really going to be a cure for this, isn't it? And I always tell patients, this is America. If somebody really had the cure, boy, they would be marketing it, and they would be obviously bazillionaires. So I think that kind of conspiracy theory I would very much try to get away from. But secondly, I do underscore what Craig said. A patient came in recently and told me that they were going to an outside clinic where they were getting chemo, but they were also getting supplements given IV, and they were asked to pay $4,000 a week for those supplements. Again, not FDA approved, no data, but that this particular family was actually scraping together money to pay for it. And I really, really think that's a bad use of money. Better off to go powder skiing, I guess.
I would say. It's always the right answer.